The most common indications of non-invasive, what we are doing is, yes, it's acute exacerbation of COPD. It can be used in the ICUs, it can be used in the wards, it can also be used on home basis. Acute cardiogenic pulmonary edema, yes, it is also being used. As I told you, these are the main top two indications where we are currently using it. Bronchial asthma is there, but yes, it's down the list. And post-extubation respiratory failure, once the patient comes out of the OT, post-surgical also, sometimes just after extubation we are using it, or sometimes we are using non-invasive for weaning the patients. That being a COPD patient who just has now been on a machine where you can electively extubate and take the patients onto non-invasive so as to decrease the chances of and complications of invasive mechanical ventilation. Those patients of immunosuppressed or immunocompromised patients or do not resuscitate patients, they are the ones where non-invasive ventilation can be given, and that has been tried. Do not intubate patients is just as a thing just to support ventilation. Mind you, that is it just to see that avoid respiratory distress, but these are the things. So now the symptoms, as I told you, exact indications. As I told you at the start, India is one of the largest users. At the same time, we also need to see what are the failures. So selection of the patient has to be extremely proper. The indications need to be selected. Just because the patient non-invasive, he's had a stroke and he cannot protect, he's got a brainstem stroke, he's tachypnic, he's conscious, does not mean that he fulfills the criteria for non-invasive ventilation. Because his airway cannot be protected, he's aspirated, it's possible that that patient still needs to be intubated because the patient, despite the GCS is better, he could be aspirated. Now you need to select the right patient, as I told you, to avoid the failure. See that the patient is of acute hypoxemic respiratory failure or a COPD with acute exacerbation, cardiogenic pulmonary edemas, mild to moderate amount of community-acquired pneumonias, or immunocompromised patients. And you should see that these patients are tachypnic. The patients have got signs of respiratory distress, where you got flaring up of the ala nasi, or you have got the sternocleidomastoids, which can be prominent, or there is an intercostal drawing which can be seen. And these are some of the indications of respiratory distress, where you need to see the patient clinically, and that will help you to identify respiratory distress even by observing the patient. The paradoxical breathing is also very important. So selection is the most important thing, indication, and that will help you to have failure. So the failure can be avoided. See that the patient is hemodynamically stable. You need to have a cooperative patient. You need to inform and discuss with the patient that what are you going to do. It's like a procedure. Initiation of non-invasive should be appreciated and taken as a procedure, and definitely you should inform to the patient, because you need to have control and compliance of it. They see that the patient is able to maintain the breath, and he's having a good cough reflex, and he's not severely acidotic, and the pH is not below 7.1, so there is a good amount of gas exchange, and the patient is not obtended. That is extremely important, has to be seen. Now, once you are going to have initiation, the respiratory arrest, or which is there, or hemodynamic instability, I told you, the patient cannot maintain the airway. These are certain factors where you need to electively intubate the patients and put them onto invasive mechanical ventilation. Now, exclusion criteria, as I told you, is again a brainstem injury or a massive pneumothorax. If the patient has got facial traumas, and in case there is a fracture mandible trauma or in a polytrauma patient, please do not start it. And you need to really sometimes use a different ways of intubation and mechanical ventilation. So this is just a picture to show that the sister explains. Along with the sister, you as a doctor need to spend time next to the patient when you're going to initiate non-invasive mechanical ventilation. Yes, in COVID, you should have a full PPE, you should wear full protective gloves, you should have definitely the face shields which are also on, and then you should preferably initiate it under acrylic box. You can also have an acrylic box which can be put so on the supine or propped up position over the patient, and then you can initiate non-invasive on that, so that you avoid spillage, and aerosol dispersion is also going to be less. And even in this, you should start off with low pressure, so that definitely it is going to be better. Definitely you will avoid aerosol dispersion. Do not start non-invasive mechanical ventilation in COVID patients unless you are fully protected yourself, and the criteria for starting it in COVID patient and see that the patient does not have a bad PF ratio. It should be above 200. Only in mild cases or mild to moderate you can use it, but please do not start it in moderate or severe respiratory failure as far as COVID is concerned. Even in those patients who have got a massive pulmonary edema, who is in cardiogenic shock, it is not the right choice. Sometimes you need to electively intubate the patient and ventilate the patient. So that is very, very important. This is a good picture to show initiation, but in these COVID patients, please do not sit next to the patient, please, and then initiate it. You have to take proper precaution. This picture is only for pictorial view.